Question 1. Which of the following is true regarding sick sinus syndrome? A. Long-term treatment generally involves pacemaker and antidysrhythmic. B. The condition is more common in patients younger than 40 years. C. Lidocaine is the mainstay of management of acute tachycardias. D. Atropine is ineffective at improving bradycardia. E. Atrial fibrillation is almost never present. Answer is A. Long-term treatment generally involves pacemaker and antidysrhythmics. Summary. Answer A. Sick sinus syndrome represents a range of dysrhythmias due to sinus node dysfunction, causing bradycardias, narrow, complex tachycardias, and combined states. It is treated by limiting the extent of the bradycardia with a pacemaker and the tachycardia with an antidysrhythmic agent. It is usually seen in older patients or in patients taking atrioventricular nodal active agents. Lidocaine is used for ventricular dysrhythmias and has no role in the management of sick sinus syndrome. Atropine is the first-line agent for sick sinus patients with severe bradycardia. Atrial fibrillation is a common tachydysrhythmia seen in sick sinus syndrome. Question 2. Which of the following is an indication for Fab fragment administration in the setting of a digoxin overdose? A. All pediatric ingestions, regardless of the amount ingested. B. Potassium level 5 MEq per L. C. Normal sinus rhythm with occasional PVCs. D. Digoxin level 2 ng per ml in the setting of acute toxicity. E. Digoxin level 2 ng per ml in patients with lightly chronic toxicity. Answer is B. Potassium level 5 MEq per L. Summary. Answer B. The use of digoxin-specific Fab fragments to treat digoxin toxicity has dramatically decreased morbidity and mortality from digoxin toxicity. Fab fragments should be given to any patient presenting with hemodynamic instability, malignant or symptomatic rhythm disturbances, any ventricular arrhythmia, high-grade AV block, Mobitz type I second-degree block or third-degree heart block, as Mobitz type 2 almost never occurs in the setting of digoxin toxicity, symptomatic bradycardia, a potassium level 5 MEq per L. An elevated potassium level is a marker of toxicity rather than a cause of toxicity, or a digoxin level 10 ng per ml in the acute setting or 4 ng per ml in the chronic setting. The drug level can be used to determine the number of vials needed. Digoxin ng per ml times patient weight, kg, 100 is equal to number of vials needed. However, patients who arrive in the ED with a clear indication for Fab administration should be given Fab empirically, 10 vials in acute toxicity. 5 vials. Question 3. A 24-year-old healthy female is brought to the ED by EMS after having ingested a large number of her mother's digoxin tablets. Her EKG reveals asymptomatic sinus bradycardia with first-degree AV block and occasional PVCs. Her vital signs reveal a pulse of 48 but are otherwise normal. Subsequent laboratory tests demonstrate a potassium level of 6.8 MEq per L. How should the elevated potassium level be treated? A. Intravenous Digibind, Fab, administration. B. Intravenous calcium chloride. C. Intravenous sodium bicarbonate infusion. D. Continuous albuterol nebulization. E. Intravenous insulin and intravenous dextrose. Answer is A. Intravenous Digibind. Summary. Answer A. While hyperkalemia is very common in the setting of digoxin overdose, it is not a cause of digoxin toxicity but rather a manifestation of toxicity. Furthermore, the specific treatment of hyperkalemia in this setting has not been shown to reduce mortality. However, Since hyperkalemia is a sign of significant toxicity in the setting of digoxin overdose, its presence is a well-defined indication for digoxin FAB administration, Digibind. Digoxin-specific FAB administration should be given to all patients with a potassium level 5.0 MEq per L. Hyperkalemia will resolve with FAB administration itself. Additional therapy with conventional therapies for hyperkalemia is not necessary and may precipitate hypokalemia once FAB is given. In addition, calcium administration is a classic contraindication in the setting of digoxin toxicity because of the risk of stone heart or sudden cardiac arrest. Question 4. Which of the following is true regarding aortic dissection? A. Dyspnea is the most common symptom. B. Syncope often indicates pericardial effusion and tamponade. C. Aortic regurgitation occurs in most cases. D. Dissection into coronary arteries occurs most often in the left coronary artery. E. Interarm differences in SBP of greater than 20 mm Hg occur in most patients. Answer is B. Syncope often indicates pericardial effusion and tamponade. Summary. Answer B. Syncope with aortic dissection mandates evaluation of the pericardial space to check for hemopericardium and tamponade. Dissections extending back to the pericardium are ascending and should be taken emergently to surgery. The most common symptom of aortic dissection is chest pain, although dyspnea is often seen as well. Aortic regurgitation is not usually seen in aortic dissection but indicates a valvular disruption when present. Dissection into the coronary arteries occurs rarely, but when it does, the right coronary artery is most frequently affected. Interarm differences in blood pressure due to unilateral extension of the dissection into the subclavian artery occur in the minority of patients with aortic dissection. However, in patients with undifferentiated chest pain, interarm differences of greater than 20 mm Hg indicate a higher likelihood of aortic dissection. Question 5. A 54-year-old man presents with a 4-hour history of chest pain, which has resolved at presentation. He also complains of diaphoresis, shortness of breath, and orthopnea. Vital signs are 98.6, 60, 22, 97 68ths, 92% on RA. Physical examination demonstrates an S3 and bilateral crackles to the midlung fields. The EKG is shown. Which of the following is the most appropriate definitive management? A. Admit for immediate percutaneous transluminal coronary angioplasty. B. Admit for immediate fibrinolytic therapy. C. Admit for immediate upper endoscopy. D. Admit for immediate heparin, G2B3A inhibitor, and cardiac care unit admission. E. Discharge home for outpatient stress test. Answer is A. Admit for immediate percutaneous transluminal coronary angioplasty. Summary. Answer A. The patient has acute anterior send segment elevation myocardial infarction with evidence of congestive heart failure due to cardiogenic shock. In these patients, immediate angioplasty has been shown to reduce mortality more than fibrinolytic therapy and is the preferred definitive therapy. Choices C and D are not appropriate for patients with acute STEMI. Choice D represents treatment of a non-ST segment elevation myocardial infarction. Question 6. Which of the following is the most common symptom in patients diagnosed with an abdominal aortic aneurysm? A. Nausea. B. Abdominal distension. C. Constipation. D. Urinary retention. E. Asymptomatic. Answer is E. Asymptomatic. Summary. Answer E. Aneurysms are most often asymptomatic and diagnosed incidentally on routine examination or imaging studies. Most symptomatic patients complain of vague abdominal pain or abdominal distension, although urinary retention and constipation may occur. Nausea occurs only in the setting of other symptoms pointing to the diagnosis. Acute abdominal pain or distension in patients at risk for AAA indicates rapid expansion or rupture. Question 7. Which of the following has the highest sensitivity for acute MI in the first 2 hours? A. Troponin I, B. Troponin T, C. Myoglobin, D. CKMB, E. Total creatine phosphokinase, CPK. Answer is C. Myoglobin. Summary. Answer C. Myoglobin has excellent sensitivity and negative predictive value for acute MI early in the course of the disease, beginning to rise within 2 hours post-infarct and peaking at 5 hours. The specificity of myoglobin is lower than that of troponin I, troponin T, or CKMB due to its release by skeletal muscle during trauma and exercise. Myoglobin is far less useful as a test in patients who present more than 12 hours after onset of symptoms. Question 8. A 65-year-old man presents with a syncopal event without prodromal symptoms. His vital signs are 98.6, 60, 18, 142 by 75, 99%. The EKG is shown. Which of the following is the most appropriate next step in management? A. Admit for observation. B. Cardioversion at 50 joules. C. Defibrillation at 200 joules. D. Amiodarone 150 mg for E. Admission and pacemaker placement. Answer is E. Admission and pacemaker placement. Summary. Answer E. The patient has Mobitz type 2 second-degree AV block, which is an indication for admission to a telemetry unit and possible pacemaker placement. The PR interval is prolonged and does not show any observable pattern of increasing prolongation as in Mobitz type 1 second-degree AV block, Wentbach phenomenon. Dropped QRS complexes do not occur in any predictable pattern like they do in Mobitz type 1. Cardioversion and amiodarone are not indicated in stable brachydysrhythmias, and defibrillation of an awake patient is never indicated.